Hello, this is Dr. Thomas again. Today we are going to be discussing another very important topic in clinical medicine, namely serum proteins. We will describe the physiological roles of major serum proteins. We will interpret the significance of serum protein levels and fractions, utilize serum protein electrophoresis in clinical reasoning, and finally recognize patterns in disease states and apply diagnostic strategies. Introduction. The following are the teaching points. Total serum protein equals albumin plus globulins. It reflects synthetic function, nutritional status, immune status, and inflammatory response. Measured in routine complete metabolic panel, refined by serum protein electrophoresis. Memory point. Serum proteins are not just numbers. They are dynamic markers of multiple organ systems. Normal ranges and components. Total protein. Normal range is 6.4 to 8.3 gram per deciliter. Albumin level is normally between 3.5 to 5.0 gram per deciliter. Globulins between 2.0 to 3.5 gram per deciliter, and normal albumin globulin ratio is 1.2 to 2.0. Albumin, the major player. Its functions include maintain oncotic pressure, transport hormones, drugs, calcium, and fatty acids, acts as an antioxidant buffer, synthesized exclusively by liver, approximately 14 grams per day. Its half-life is approximately 21 days. Causes of low albumin level. Number 1, decrease in synthesis as occurs in liver disease and malnutrition. Number 2, increased loss as happens in nephrotic syndrome and protein losing enteropathy. Number 3, redistribution or dilution as occurs in sepsis and IV fluid overload. Number 4, negative acute phase reaction as occurs in inflammation. Memory point. Albumin drops in sickness before you even realize the patient is sick. Globulins. Divided into alpha-1 globulins such as alpha-1 antitrypsin, alpha-2 globulins such as haptoglobin and ceruloplasmin, beta globulins such as transferrin and complement. Gamma globulins include IgG, IgA, IgM, IgD, and IgE. Produced by liver and plasma cells. Acute phase reactants and serum proteins. Albumin is a negative acute phase reactant, which means albumin level goes down during inflammation. Fibrinogen, on the other hand, is a positive acute phase reactant and its level goes up during inflammation. CRP also is a positive acute phase reactant. Haptoglobin is a positive acute phase reactant. Transferrin, on the other hand, is a negative acute phase reactant. Memory point. Always interpret albumin in the inflammatory context. Albumin to globulin ratio. Clinical use. Low albumin globulin ratio occurs due to low albumin as occurs in cirrhosis and nephrotic syndrome. High levels of globulin as in multiple myeloma and chronic infection causes low albumin to globulin ratio. High albumin globulin ratio occurs rarely as occurs in A-gamma globulinemia or due to technical errors. Memory point. A low albumin globulin ratio is often a flag for serum protein electrophoresis. Serum protein electrophoresis. Serum protein electrophoresis produces several peaks. The first peak is albumin. It is the largest and sharp peak. Second peak is alpha-1 globulins. Third peak is alpha-2 globulins. Fourth peak is beta globulins. And the last peak represents gamma globulins. Interpretation patterns. M spike in gamma region occurs in monoclonal gammopathy. Polyclonal gamma increase occurs in autoimmune disease and cirrhosis. Decreased albumin plus increased alpha-2 globulin occurs in nephrotic syndrome. Memory point. Add immunofixation to confirm monoclonal bands. Serum protein electrophoresis. This diagram represents serum electrophoretic pattern in various conditions. Common clinical patterns. Decreased albumin only occurs in liver disease and inflammation. Decreased albumin plus increased alpha-2 globulin occurs in nephrotic syndrome. Polyclonal increase in gamma globulins occurs in chronic liver disease and infection. Sharp monoclonal gamma spike occurs in multiple myeloma and MGUS. Broad gamma increase plus decreased albumin occurs in cirrhosis. Case examples. Case 1, cirrhosis. The following are the findings. Decreased albumin, polyclonal increase in gamma globulin, normal to low total protein. Case 2, multiple myeloma. The following pattern occurs. Normal or high total protein. Number 2, normal albumin. Number 3, monoclonal spike in gamma globulins. Case 3, nephrotic syndrome. The following are the features. Decreased albumin, increased alpha-2 globulin, and urinary protein more than 3.5 gram per day. Diagnostic workup when abnormal. Check serum protein electrophoresis plus or minus immune electrophoresis. Order urine protein electrophoresis for Bence-Jones proteins. Evaluate liver function, renal function, and urinalysis. If high gamma globulins, then consider hepatitis C virus infection or order autoimmune serologies. If monoclonal spike, then think about bone marrow biopsy. Limitations and pitfalls. Pseudohypoalbuminemia could be due to dilutional effect or technical artifact. Total protein may appear normal despite abnormal fractions. Hemolysis and lipemia can affect results. Clinical pearls. Albumin is a late marker of chronic disease, not for acute changes. Always correlate serum protein electrophoresis patterns with clinical context. In hypoalbuminemia, evaluate for renal loss, hepatic dysfunction, or malabsorption. Serum protein changes can precede symptoms. Useful in monitoring chronic disease or malignancy. Summary. Serum proteins reflect number 1, liver synthetic function, number 2, nutritional and inflammatory status, number 3, immune and oncologic activity. Use patterns, not just values. Quantitative tests such as CMB plus, qualitative tests such as serum protein electrophoresis or immune electrophoresis. Interpret in context: hepatic, renal, oncologic, and systemic diseases. The following are the suggested readings. Thank you for listening. See you next time.